Thank you for taking time out of your busy schedule to review this package. I'm Matt Davis, Medical Director for SWORBHP Base Hospital. This is a very quick update for all base hospital physicians in our region. The ALS PCS has recently been revised, and with these revisions comes a new PCP directive and a new ACP directive that contain patch points. The purpose of this teaching package is to update you as base hospital physician and to familiarize yourself with these patch points as to when and why paramedics will be patching and what they will be patching for. PCP's scope of practice has extended with version 3.3 of the ALS PCS to include the treatment of opioid toxicity. Within this protocol is a mandatory patch point for the administration of naloxone. Indications for naloxone are altered LOC, respiratory depression, inability to adequately ventilate with BLS airway maneuvers, all in the setting of suspected opioid overdose. Patients must be 18 years of age or older, have a respiratory rate of less than 10, and cannot be hypoglycemic or have a known allergy to naloxone in order to receive this medication. In order to proceed with the administration of naloxone, the PCP paramedic will patch to the BHP. The preferred route is subcutaneous, followed by IM, then IN, and IV respectively. The paramedic will use their clinical judgment as to which route is safest, and will likely request this route when patching. The dosage are listed in the following table. Below are some clinical considerations when using this directive. PCPs must be IV certified in order to give the medication through the IV route. Paramedics are also strongly encouraged to make every effort to transport patients who have been administered naloxone. Of paramount concern is paramedic safety, which is why BVM with basic airway management and oxygenation, when adequate, is preferred over naloxone administration. The second major change is the introduction of a hyperkalemia medical directive for the ACP scope of practice. The treatment of suspected hyperkalemia requires a patch to the BHP in order to proceed. A patient who is in cardiac arrest and is currently on dialysis or has a history of end-stage renal disease, or the paramedic is highly suspicious as hyperkalemia as the cause of the cardiac arrest, would qualify for the administration of the medications in the hyperkalemia directive. Patients who are also in a pre-arrest situation, which includes hypotension, experiencing an altered level of consciousness, or having symptomatic bradycardia with a 12-lead ECG suggestive of hyperkalemia, would also meet the indications for the administration of the medications within this protocol. In order to receive calcium gluconate or salbutamol in the setting of hyperkalemia, patients must be 18 years of age or greater. Contraindication to calcium gluconate therapy would be a patient who is currently on digoxin. A contraindication for salbutamol is any patient who has a known allergy or sensitivity to it. When patients meet the indications, conditions, and have no contraindications, paramedics will patch to receive orders to proceed with the administration of calcium. The dose of calcium is 1 gram given over 2 to 3 minutes via the IV or IO route. The paramedics can give a maximum number of 2 doses with 30 minutes between dosages. Salbutamol can be given to patients who are suspected to be hyperkalemic in the pre-arrest situation or in those who are experiencing cardiac arrest. Salbutamol can be given by the MDI route or nebulized route. For the MDI route, 16 puffs will be administered by the paramedics, whereas by the nebulized route, 10 milligrams will be nebulized. Sodium bicarbonate is not included in this directive. If you as BHP feel that the patient would benefit from sodium bicarb, then be aware that the ACPs do carry this medication and can administer it. They are aware of the limited evidence that sodium bicarbonate may be effective in acidotic patients. Thank you for reviewing this information. I hope it will prepare you for these particular patch points. If you have any questions, please do not hesitate to contact your local medical director for your area, myself, or Mike Llewell, the Regional Medical Director for SWORBHP.